Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me one of the leading KOLs in the multiple myeloma field, Dr. Binod Dhakal, Professor of Medicine in the Division of Hematology at the Medical College of Wisconsin. And today, in the Conversation with Cancer Experts series, the topic of discussion is something that is starting to have a lot of chatter. It is in vivo CAR Ts. Are these the wave of the future? Welcome, Binod.
Thank you so much, Rabi. Thank you for having me again.
So the thing is that there's been a lot of discussion now about taking CAR Ts to the next level. So can you tell us about what this experience that has been presented now more than once at EHA, ASCO, at ASH
Mhm.
is all about? What's creating the excitement?
Yeah, I mean, we have CAR-T is quite exciting in myeloma, and we have already know that it is already approved in the second line, with showing very high responses, PFS and OS advantage compared to standard of care. But the autologous CAR-T has its own challenges, including the manufacturing, apheresis, logistical challenges of lymphodepletion, some potential long-term side effects from that. So I think this is a very fascinating concept of where you can generate the CAR T, manufacture in your own body instead of ex vivo manufacturing. So the in vivo CAR T is something that has been in work for several years, but now this is the first of that translating into the clinic. So the data, the concept itself is very exciting, and what we saw in the data at last ASH and subsequently at ASCO and also at EHA looks that this is a very highly promising therapy that can overcome a lot of challenges as long as the safety and durability of the responses remain favorable as you follow these patients longer.
So this particular in vivo CAR T, can you tell us about how it functions and what the construct is?
Yes, so this is lentiviral particles. There are different ways you can generate the in vivo CAR T. You can generate in lentiviral particle, which is the standard lentiviral vector that we use in the CAR T, versus you can use the mRNA-based, lipid nanoparticle, and there are multiple other ways. But this particular Kelonia product is based on the in vivo gene delivery using lentiviral particles. Here you can see in the cartoon that vector is inserted into this capsule, or this particle, where you have this fusogen from VSVG that is mutated to target to the T cell, and at the same time there is a CD3 retargeting with the CD3 topism in the T cell. So this particle can selectively target the T cell through this mechanism, and so the virus can get inserted in the T cell. So it's kind of a in that setting, it's kind of a very interesting kind of way of delivering this particle, the viral particle, into the T cell.
And it seems like you
Also,
don't have to give any lymphodepleting
correct,
chemotherapy.
correct. So there is no need of lymphodepletion. The patient can just get infusion of the viral particle, where here this lentivirus vector is given to the patient directly, where the virus can get, this can get attached to the T cell, and this the lentiviral vector directly goes into the T cell and inserted into the DNA, and then generate the CAR T construct. And the CAR T construct, as you can see, is fully human BCMA with the SCFV chain with the 4-1BB co-stimulating domain and CD3 zeta signaling domain. So that is pretty consistent with what we use in the other autologous CAR T.
So it seems like this can be done in facilities that don't have any pheresis units, don't have any cryopreservation facility.
Correct.
It kind of could democratize CAR T if it comes to pass.
Correct. So the ex vivo process, everything can be omitted completely. So it's just like the patient, that the post monitoring is different after you infuse this product, but the initial phase of the manufacturing, and then LD chemo, and then all this process can be completely taken off.
Yeah, and some of the concerns that have been raised that, especially in heavily pretreated patients, you already have some genetic changes that have occurred in the myeloid compartment of the marrow, and not having to expose patients to fludarabine and Cytoxan could have advantages of its own.
Correct. That is a potential theoretical advantage of not using the lymphodepletion. At the same time, also not need to wait for these patients for a longer period of time, especially, when you're thinking of patients who need the therapy right now or in very rapidly. I think this can be a very useful strategy.
So can you tell us about the study that we're going to
Yeah, so
discuss
this is
briefly?
also the phase one, 3+3 dose escalation and backfill cohort study, where standard patients with the three prior lines of therapy and exposure to three basic class of drugs were included. As you can see, the primary endpoint, because the phase one dose escalation, is safety and tolerability and finding the recommended phase two dose. And the secondary endpoints is looking at the CAR-T kinetics and as well as the say a preliminary efficacy. So there are three doses were tested, starting from 2 in 10 to the power 7, IU per kg, and then going up to 4 into 10 to the power 7 IU per kg. And there are some backfill cohorts, and then the plan is to expand that remaining cohorts to go to the recommended phase two dose.
And what kind of patients were accrued?
Yeah, so this is a total of 18 patients. Initially, we had a study on only 4 patients, and this is now expanded to 18 patients. And as I said, this is standard relapsed refractory myeloma population which were like three prior lines of therapy. The median age was 67, and high risk cytogenetics was between 72% of patients. EMD at baseline is 28%, so kind of heavily treated patients in that count. The median prior lines of therapy is 3.5. So, that's what you would expect if you have three prior lines of therapy. And majority of the patients are refractory to all three major classes of drugs, more than 70% of the patients. So that is kind of, in terms of patient category, there is nothing unusual, which is that is usual what we'd expect with this patient population.
And what were the results?
I mean, the results look quite exciting. The response rate was 100%. Essentially, everybody responded. Again, it's 18 patients, but it's quite promising at this stage. And if you look at all patients, there are 100% response rate. And when you look at the patients with longer follow-up, the response rate continue to remain at 100%. And pretty high MRD negativity rate of the patients who had evaluable MRD negative response of 14 patients. Everybody achieved MRD negative, which is again quite impressive. So at this time, I think it's pretty fascinating. I think there is one patient who had progression, and the one patient who had MRD resurgence, which is kind of, I would say this is not something to be worried about, because this is, you would expect, for any other CAR-T to have this kind of efficacy responses.
So how long do these CAR-Ts last in the body without lymphodepletion?
Yeah, so that is a kind of interesting question. But when you look at this, the kinetics of this CAR-T, I mean, it's not unusual. This is not kind of different than what we have seen with the auto CAR-T, actually. Maybe perhaps you can increase the persistence or expand a little bit more with the LD chemo, but you can see here in all the three dose levels, here you see the median persistence about 60 plus days. And in the high dose, you are 110 days. Actually, this is, you see with the cilta-cel, maybe not with ide-cel, but I think this is consistent with what you see with the autologous product. Maybe perhaps you can push that a little bit with the lymphodepletion, but also at the same time, we talked about lymphodepletion has its own price. So I think it will be interesting to see when you talk about this in vivo delivery technology, in vivo CAR-T. I mean, as you know, there are a lot of other in vivo CAR-T product that is being investigated in myeloma and lymphoma. I think it would be worthwhile to explore that strategy with the lymphodepletion, without lymphodepletion, how would that impact? But just looking at the kinetics at this stage, I don't think we need the lymphodepletion.
And how did people tolerate it?
Yeah, I mean, in terms of CRS, there was no, at least for these 18 patients, there was mainly grade 1 and 2. There is no grade 3 CRS, which is good. And the dose you use used as liberally as possible. In terms of ICANS, there was one grade 3 ICANS. Again, we need to look at, I think this patient had a higher disease burden from what I recall. But this is something that we need to look at. This and other, of course, long-term safety. We need to look at how does it impact that. But right now, at least at 4-month follow-up, they didn't see any evidence of delayed neurotoxicities and other delayed toxicities that you would sometimes worry about with this kind of technology.
And anything else emerge in terms of toxicities other than the CAR-T specific
Yeah,
toxicity?
I mean, when you look at the grade 3 infections, again, very low number of grade 3 and higher infections. Cytopenia is also not that very high when you talk about grade 3 and higher cytopenias. There were some infusion related reactions. There were mainly grade ones. There was one grade 3 and higher, mainly otherwise grades 1 and 2, something that probably would something we need to keep an eye in terms of pre-medication. But after that one episode, pre-medication dexamethasone was implicated, and there were no evidence of IRRs, which is quite kind of encouraging. And it is something that can be also administered in the outpatient given this overall safety profile.
So once again, can you summarize this for us, this experience to date?
Yeah, so the in vivo CAR T at this stage looks very early but very interesting and promising. We still need to see more data from more number of patients, and also see a little bit longer follow-up of these patients to really see how does it impact, and also how does it impact the patients who already had the prior BCMA therapy exposed, or prior CAR T treated patients, or bispecific treated patients. How does it impact, and whether delivery technology and also the CAR T generation is efficient even in those patients. That is something to look at. But right now, I think it is quite promising in a sense that this can be given directly to the patient in the absence of apheresis, in the absence of lymphodepletion. What we saw in those 18 patients, the responses rates were quite impressive. Everybody achieved MRE negative responses, and then majority of them sustained for 6 months and beyond. So this is quite exciting. In terms of safety wise, I would say that safety looks quite encouraging as well. Because mainly grade 1 and 2 CRS, there is no grade 3. There is only one grade 1 ICANS. That could be just one patient profile that you probably can expect with any other CAR T. Cytopenias and grade 3 4 infections are also very, very small. So, and IRRs were low or non-existent after you start the pre-medication. So I would say that this technology is, again, a lot of other constructs are right now in development and moving very rapidly. It'll be exciting to see once you treat more patients, and also treat different kind of patients, like who, as I said, who are treated with the BCMA CAR T, BCMA bispecific, because as these therapies are moving early line, we need to see whether this this kind of technology would work in that patients as well.
So what are the potential side effects or concerns with longer term follow-up that you're looking out for?
Yeah, I think this along. How did the integration, the random integration to the T cell, how does it, again, you could argue that in autologous CAR T also there is no, kind of there is no control on the random integration that happens in that same way. But at the same time, we also don't really know, once you have this, vector infused into the patient body, how does it really integrate only to the specific T cells, and how we can make sure that it's not integrated into other random cells that we are worried about for the long term, any kind of let's say second cancers, let's say any other kind of inflammation or any toxicity that could happen from that. So this is probably one of the potential uh, concern, especially following this long term. And in terms of durability, is it really gonna last longer? In terms of efficacy, we don't know that, but I think right now it looks very encouraging.
So I want to thank you very much for bringing us up to date with this exciting development. Seems like science fiction coming true in some ways. And as the story evolves, obviously we'll be glued to our seats to give us some updates on how this has moved forth.
Thank
Thank
you
you
so
very
much.
much.
Yeah.
Thank you.